Today, I'll be presenting a comparative exploration of two evidence-based approaches to addiction treatment: cognitive behavioral therapy, or CBT, and motivational interviewing, or MI for short, applied to the case of Jesus, a 16-year-old Hispanic male with symptoms consistent with internet gaming disorder, or IGD. The presentation will address assessment, diagnosis, level of care, cultural considerations, treatment planning, relapse prevention planning, and concluding with the benefits and limitations of each approach. This framework is informed by current literature which underscores the need for individualized treatment planning that integrates culturally responsive care and evidence-based practices. Jesus is a 16-year-old Hispanic male who presents with declining academic performance, withdrawal from in-person social interactions at school, and excessive engagement in cooperative online video games, games such as Borderlands, Overwatch, and Modern Warfare. While socially withdrawn in face-to-face contexts, he maintains active social connections online. His parents have expressed concern over his emotional detachment from family life, increased conflict with siblings, and a tendency to prioritize gaming over academic responsibilities. These behavioral patterns align with findings that excessive gaming can impair multiple domains of adolescent functioning, including academic achievement, social relationships, and emotional regulation. Internet gaming disorder emerged as a research topic in the early 2000s when mental health professionals began noticing problematic gaming behaviors that resembled patterns seen in substance addictions, such as preoccupation, withdrawal, tolerance, and impairment in daily functioning. Much of the initial work built on pathological gambling research, exploring whether similar diagnostic criteria could apply to excessive gaming. In 2013, the American Psychiatric Association included IGD in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, or DSM-5, under Section 3, labeled Conditions for Further Study. This classification meant that IGD was not yet an official disorder, but was presented with proposed diagnostic criteria requiring at least 5 of 9 symptoms. For example, preoccupation, withdrawal, loss of control, jeopardizing relationships. These 5 of 9 symptoms to be present within a 12-month period. The World Health Organization took a significant step in 2018 by formally recognizing gaming disorder in the International Classification of Diseases 11th revision, or the ICD-11, defining it by impaired control over gaming, increased priority given to gaming over other activities, and continuation or escalation of gaming despite negative consequences. The ICD-11 classification came into effect in January of 2022, allowing for standardized diagnosis and treatment worldwide. In the United States, IGD remains listed in the DSM-5-TR as a condition for further study, while many countries have adopted the ICD-11 criteria, enabling clinical recognition, insurance coverage, and continued research into prevalence, cultural differences, and treatment approaches. Based on the DSM-5-TR proposed diagnostic criteria for internet gaming disorder, Jesus meets at least 5 of the 9 criteria: preoccupation with gaming, withdrawal symptoms when unable to play, tolerance or needing to play more to achieve satisfaction, loss of interest in other activities, deception regarding gaming, and continued excessive use despite problems. This pattern indicates a moderate severity level. Rule-out diagnoses include major depressive disorder, social anxiety disorder, and oppositional defiant disorder, though the specificity of his symptoms to gaming behaviors makes IGD the most appropriate primary consideration. Process addictions like IGD often get less attention than substance abuse disorders. There is still a lot of stigma and discomfort around talking about process behaviors, especially when it's framed as a disorder. And because IGD is still being considered in the DSM-5, it's harder to get insurance coverage, research grants, or other institutional support for treatment studies. Issues like the opioid epidemic, for example, dominate public health funding, making it even harder for behavioral addictions to get the resources that they need. Once a diagnosis has been established, we must decide upon our assessment tools to assess Jesus in IGD. For this particular case, I would recommend using the Internet Gaming Disorder Scale short form, a psychometrically validated instrument that has demonstrated cross-cultural reliability, including in Hispanic adolescent populations. Additionally, I would use the CRA FFT screening to assess for potential co-occurring substance use. Both instruments are brief, cost-effective, and suitable for outpatient clinical contexts, aligning with the best practice recommendations for early detection of co-occurring risk behaviors in youth. The first approach that we will use is cognitive behavioral therapy. CBT is a structured, time-limited, and goal-oriented psychotherapy that aims to identify and change maladaptive thought patterns and behaviors. In Jesus's case, CBT interventions might involve cognitive restructuring to challenge beliefs about gaming as his sole source of competence and enjoyment, behavioral activation to increase participation in non-digital activities, and problem-solving skills training to improve coping with academic and social stressors. Evidence suggests that CBT can significantly reduce IGD symptoms and improve psychosocial functioning in adolescents. CBT offers strong empirical support for behavioral addictions, with the added benefit of providing skills that are transferable across life domains. However, its structured and directive nature may be challenging for adolescents who are resistant or ambivalent toward change. As is currently the case with Jesus, research indicates that while CBT is highly effective when client engagement is strong, motivational factors must be addressed first to optimize outcomes. The second approach I'll use is motivational interviewing, or MI. MI is a client-centered and directive counseling method designed to enhance intrinsic motivation for change by exploring and resolving ambivalence. For Jesus, MI techniques such as reflective listening, affirmations, and strategic summarizing can create a non-judgmental space in which he feels respected and understood, thereby increasing his willingness to consider behavioral changes. MI has been found effective in engaging resistant adolescent clients and is particularly adaptable to culturally diverse populations. As with CBT, MI has benefits and limitations that must be noted. MI's strengths lie in its ability to increase engagement, respect client autonomy, and work effectively across cultures. In Jesus's case, integrating cultural values such as familismo, or loyalty to family, respeto, respect for authority, and personalismo, warm interpersonal relationships, into MI conversations can enhance relevance and buy-in. The primary limitation is that MI does not directly teach behavioral skills, which means sustained improvement may require combining MI with a more structured approach, like CBT. For this comparison table, we will be comparing and contrasting CBT and MI. As you can see by the table shown here, this comparison highlights how CBT and MI differ in focus, structure, and best fit client profiles. For Jesus, beginning treatment with MI could help build readiness and trust, making him more receptive to the structured skill building offered in CBT. This sequential integration is supported by evidence suggesting that pairing motivational enhancement strategies with cognitive behavioral interventions can produce greater adherence and longer-term outcomes in adolescent addiction treatment. Based on the ASAM criteria, standard outpatient services are clinically appropriate for Jesus. There is no indication of substance use or withdrawal symptoms requiring medical oversight or Dimension 1, and no biomedical instability reported or Dimension 2. While Jesus may experience symptoms of anxiety or depression, they are not acute and can be effectively managed through outpatient cognitive behavioral therapy and MI, motivational interviewing interventions. Should this change or assessments show otherwise, levels of care would, of course, change. His motivation for change appears mixed, which is common in IGD. However, research supports the use of motivational interviewing and cognitive behavioral therapy in outpatient settings for ambivalent adolescents. Although the risk of continued gaming is high due to its accessibility, outpatient treatment allows for effective relapse prevention. Strategies such as digital hygiene plans, parental involvement, and behavioral contracts. Jesus's home environment is stable, and his family is willing to engage in treatment and make necessary changes, including setting internet limits and establishing structured routines. Given Jesus's moderate symptom severity, absence of acute safety risks, and the presence of a supportive home environment, outpatient treatment is the most appropriate level of care. Intensive outpatient programs or residential treatment may be considered only if symptoms worsen or function declines despite outpatient intervention. This recommendation aligns with stepped care models that prioritize the least restrictive but effective. Goal 1 of Jesus's treatment plan. For our first goal, we're addressing Jesus's high gaming engagement by helping him create balance in his daily life. We'll start by tracking his gaming time so both he and his family can see patterns and triggers. Using CBT, we'll work on challenging his belief that gaming is his only enjoyable activity, and we'll schedule alternative leisure activities to broaden his interests. With MI, we'll explore his own reasons for change and use a decisional balance exercise to help him weigh the pros and cons of reducing gaming. This combination supports both skill development and internal motivation for healthier habits. Goal number 2, improve academic performance and study habits. The second goal focuses on Jesus' academics. By structuring his study time and holding him accountable for completing assignments, we target the decline in school performance. CBT will be used to teach practical skills like time management, organization, and problem solving, especially when procrastination sets in. MI will help connect his schoolwork to his personal values and long-term goals, making the work feel more meaningful to him. This pairing encourages him to take ownership of his success while also giving him tools to manage school demands effectively. Goal 3, increased social engagement and peer connections. Our third goal is to help Jesus reconnect socially outside of gaming. We'll begin with small, manageable steps, like one in-person peer interaction per week, and work toward participation in an extracurricular or community activity. CBT interventions will include role-playing and gradual exposure to social situations, while MI will guide conversations about why real-life friendships matter to him personally. Building these connections will not only reduce his dependence on online interactions, but also support his emotional well-being and social confidence. Goal 4, strengthen family communication and support. The fourth goal centers on family relationships, which are an important protective factor in adolescent mental health. Joint sessions with his parents will focus on teaching assertive communication and active listening skills, as well as developing a clear and agreed-upon schedule for gaming and study time. CBT provides the structure for skill building, while MI helps ensure that both Jesus and his parents feel heard and invested in the plan. This approach fosters cooperation, reduces conflict, and creates a supportive environment for ongoing progress. A CBT relapse prevention model adapted for IGD would involve helping Jesus identify high-risk triggers, develop coping strategies, and integrate balanced leisure activities into his routine. The clinician's role includes skills training, progress monitoring, and reinforcing gains, while the family's role centers on consistent support and accountability. Research shows that relapse prevention strategies incorporating family engagement lead to higher treatment adherence and better long-term outcomes for adolescents with behavioral addictions. Parents can help set healthy screen time boundaries, encourage offline socialization, and model balanced technology use. Involving school staff and possibly faith-based community groups may also provide Jesus with additional relational support. Relapse prevention planning significantly increases the likelihood of treatment success, especially for behavioral addictions such as IGD. For adolescents like Jesus, whose coping skills and identity are still in development, a structured, culturally competent plan can enhance emotional resilience and accountability. However, certain challenges may impact the effectiveness of the plan. If parental engagement is inconsistent, or if systemic barriers such as limited access to extracurricular activities or technology overuse at home are not addressed, the plan may have limited impact. Furthermore, if Jesus' gaming behavior is a primary coping mechanism for underlying emotional pain or unresolved trauma, the clinician must ensure that deeper therapeutic work is also incorporated alongside behavioral strategies. Research indicates that while overall rates of substance use among Latino populations may be lower than national averages, specific subgroups, particularly US born or acculturated Latinos, experience disproportionately higher rates of substance use disorders. In working with Mexican or Latino clients, I, as a white woman, must be mindful not only of language, but also of culturally embedded beliefs about healing, authority, and family roles. My limitations include limited fluency in Spanish, lack of exposure to traditional healing practices, and minimal firsthand experience navigating the immigration system. These limitations may hinder my ability to build trust, assess needs accurately, or collaborate with community-based supports effectively. Furthermore, I must remain aware of potential countertransference reactions, such as over-identifying with a client's oppression or avoiding difficult topics for fear of offending, which could reduce therapeutic effectiveness. Culturally responsive supervision and self-reflection are essential components of ethical practice in this area. Ethically, treatment should align with the ACA Code of Ethics, emphasizing cultural competence, informed consent, and confidentiality when working with minors. Clinically, incorporating cultural values such as familismo, respeto, and personalismo can strengthen therapeutic rapport and engagement. Using culturally relevant metaphors, language, and examples makes interventions more meaningful while balancing parental involvement with the adolescent's right to privacy fosters trust. Developing cultural awareness is a continual process that requires humility, education, and intentional engagement. As I prepare to work with clients who are Hispanic or from the Hispanic population, understanding the cultural dynamics of addiction, including family values, acculturative stress, and systemic barriers, will be critical to ethical, effective care. By addressing my limitations and actively pursuing cultural competence, I aim to serve my clients with integrity, compassion, and respect. In summary, starting with motivational interviewing to enhance readiness and rapport, followed by cognitive behavioral therapy to teach concrete coping and problem-solving skills, provides a balanced approach tailored to Jesus's needs. Outpatient care, combined with active family involvement, offers the most effective and least restrictive environment for positive change. This combined strategy is supported by research indicating that motivational enhancement prior to skill building interventions yields greater engagement and sustained behavior change in adolescents with behavioral addictions. Thank you for taking the time to listen to my presentation on Jesus and IGD.